Hi everybody, welcome back. In today's video we're going to talk about what are the components of a pharmacogenetic decision support tool, or DST. So in a previous video I talked about what makes up a reliable pharmacogenetic test, and one of the three components that made up a reliable pharmacogenetic test was the reporting section, which is generally called a decision support tool, especially if you're using commercially available pharmacogenetic tests. So what are the components of the decision support tool that should be in a decision support tool? And those have been thought about and reported by experts in the literature from the CDC, and here's the publication here if you want to go look it up, and from CPIC, which is again the Clinical Pharmacogenetic Implementation Consortium, or a group of experts that really creates pharmacogenetic guidelines. And so these two groups have both come up with consensus guidelines or guidelines within their own publications that suggest that the components of a decision support tool should have two broad categories. The first being the naming of the sequence variants and how that is reported in the decision support tool. And second, the actual components of the test reporting itself, so the lab's actual reporting of the genetic results. So let's go ahead and dive into the first section of these suggestions or group consensus guidelines of what should be included in a decision support tool, which is naming sequence variants. And so there really are 5 recommendations here. And the first is to use Hugo Gene Nomenclature Committee to specify the gene. So what does Hugo stand for? Hugo stands for the Human Genome Organization. And so often what you'll see is if you search a gene on the internet, you will go to the genes page, which there's many different gene kind of information pages you could find out there, and you'll see that a gene can have multiple, it can have 10, it can have 20 different names. And so what the Hugo Gene Nomenclature Committee does is they approve a given symbol and a name. And so what they suggest here is that the test or the decision support tool should report using the human gene nomenclature. So in pharmacogenetics, because we're doing a lot of cytochrome P450 testing, what you'll often see is some sort of CYP followed by the subfamily, such as 2D6. That is the use of a human Gene Nomenclature Committee's approved name. The second recommendation is to report variants using the Human Genome Variation Society nomenclature. So this is essentially going to be within the report reporting which variants you're testing using the approved nomenclature, which generally looks something like a portion of letters with numbers representing the genome's location, and then the actual variant you're looking at itself, if applicable, which in this case would be showing that A is the wild type allele or nucleotide and T is the variant allele or nucleotide that's being tested. For the third recommendation here, they suggest use the locus reference genomic RefSeq gene and or a specified human genome reference assembly as a reference sequence. And what does this mean? It essentially means using or telling one what gene assembly you use. So having a genome location, which usually starts with an NM and then numbers after it. And the reason they want you to report this in the decision support tool is because every once in a while the human genome is updated with a new assembly. So every few years it comes out that there's a new reference assembly that has been aligned in the human genome. And so it's good to know that, so that if you have to get into the weeds on which variants they're looking at, you can know which reference assembly they were using. The fourth, if available, to report the database SNP reference SNP identification number, or RSID. And so this is a really useful number because you can search this in databases, you can do general searches on the internet, you can do searches in PubMed or Medline. And so what this looks like is RS followed by a series of numbers, and it actually is specific to a given variant within the genome. So not all variants have this, but most of them have them now, and you should see these in your report. Finally, they suggest that the use of haplotype translation tables to convert star alleles or other legacy nomenclature to fully specified Human Genome Variation Society nomenclature for each variant within the haplotype. So that mouthful is really referring to the report telling you how they are figuring out what variants and combination of variants lead to a given star allele. So we see this a lot with SIPs. So we'll see SIP2D6, star 1, star 2, star 4, star 5. And so what they're recommending is telling you, how did you determine this patient was a star 2? Are you using the consensus approved haplotype translation tables where if a patient is a star 1, that means they have no variants. If they're a star 2, maybe they have a variant 1 and 2. If they're a star 5, do they have variants 1, 2, and 6? And so on and so forth. So you need to know what variants they're testing for so you know they are confidently determining the star alleles. Now that we've talked about naming sequencing variants, let's move on to the second part of the recommendations or guidelines from these groups, which is the test reporting itself. And so this one's a little more straightforward. In their first recommendation, the test should always indicate each variant or haplotype observed in the test report, so actually telling you the patient's pharmacogenetic results. Seems pretty obvious, but you'd be surprised. Some studies out there have found that this isn't always the case. The second, listing the variants and haplotypes that can be detected by the test. Now this one's really important because you want to know what variants they're testing for. So you can at least somewhat deduce the chance of false negatives, because if you're not going to test for it, you're not going to find it, right? So there may be rare variants or variants that are more prevalent in certain populations that maybe aren't included on that commercial or hospital test, and therefore the chance of a false negative could be reasonably high. For the third recommendation, describe the test, including limitations such as types of variants that cannot be detected. So this one piggybacks off of number 2 a little bit to tell you the variants that can't be tested, but also more referring to whether or not they can detect things like copy number variations, if that's applicable for a gene, gene duplication, and then telling you those limitations, and overall just describing the test. Is it a PCR-based test, TACMAN, sequencing, so on and so forth. For the fourth recommendation, the test should be made publicly available on the laboratory's website, so the test description, or by registration with the NIH Genetic Test Registry. And so this is straightforward. You should be able to go to the NIH Genetic Test Registry and see an example report, or at least a description of what testing they do. And then finally, the use of CPIC consensus term of allele functional status and phenotype if it's applicable to that gene. So again, in pharmacogenetics, we're doing a lot of cytochrome P450 testing. And what you may know or you may not know is that when you get a star allele status from a CYP gene, those are generally translated into a so-called phenotype that kind of looks like this. Depending on what your CYP star allele is, you could be a poor metabolizer, you could be a normal or an extensive metabolizer, you could be a rapid metabolizer, and sometimes there's even an ultra-rapid metabolizer. So the recommendations are basically saying that you should use these CPIC consensus terms, which are usually poor, extensive, rapid metabolizer, in your interpretation of the genetic results and the delivery through the decision support tool. Okay, so now that we've seen those recommendations from the CDC and CPIC on what should be included in a decision support tool in terms of naming the sequence variants and the actual test reporting itself, there's actually a third component of a decision support tool that should be considered as well. And that can be found almost always in a commercial test and even within an EMR system at a hospital, and that's the medication recommendation section. So what should you do based on these pharmacogenetic test results that are being given to you? And a lot of times these companies or in the EMR will tell you what, or at least recommend to you what you should do based on the evidence when a patient has a given pharmacogenetic test result. And the thing about this is There are no guidelines. And you kind of expect this a little bit, especially in the commercial realm, because their medication recommendation section is the main draw of their product. So they want to prove to you that their medication recommendation section is the best. So really what this comes down to is which ones actually have peer-reviewed evidence to support their medication recommendation section, which we'll talk about in a different video, and personal preferences, because these sections usually come in two different forms. Those two forms are risk-based and dose-based. So often you'll see in a medication recommendation section something like, this patient is a poor metabolizer at this gene, therefore your patient has a higher likelihood of side effects on this drug, or your patient has a higher likelihood of non-response on this drug. That would be a risk-based recommendation. A dose-based recommendation would be, your patient's a poor metabolizer for this given drug, therefore you should use 50% of the normal dose, 25% of the normal dose. Something of that nature is generally seen in a dose-based recommendation. So something to consider is how you like those recommendations to come to you, and if they're supported by peer-reviewed literature. That's going to really be the third component of a DST. Thank you for your attention.